Okay, so welcome everyone for another session with Radmasters. Today we have 4 candidates with us, and probably we'll try to show at least 6 cases to them so that you have a good overview of different kinds of cases that can come up in FRCR. So without any further ado, we'll start with the first candidate. Okay, candidate A, are you able to see the screen?
Yes, sir. I'm able to see the screen, but the lung is
Yeah,
all dark. I'm not able to.
sure. Just a sec. I think I can handle that for you. One sec. How about now? Is it better?
Yeah, it zoomed, but the lung is all.
Yeah. The image is such. The image is such.
Okay, sir. Okay, sir.
Cool.
Yeah.
So yeah, I'll just keep the timer one sec. You can
Yes, sir.
you can start.
All right, sir. So I've been presented with the frontal chest radiograph of a skeletally mature patient. So going through the image, what I see is uh, uh, an opacity, a fusiform opacity in relation to the left apex with its broad base towards the chest wall, showing obtuse angles with the lung. So probably that is a chest wall lesion in the apex of the left hemithorax. And also seeing going through the other images, going through the other uh, parts. So I see I see something expansile in the, I see an expansile lesion in the right mid clavicle with uh, with likely a pathological fracture of the same. And there is also another lytic lesion in the body of the right scapula. So considering all these findings, these are likely to suggestive of multiple metastasis. So I'll look for the I'll look for the previous images of the patient, review the clinical history of the patient, ask for any history of malignancy in the patient. And if there is no history, then I'll need, if the patient is not a known case of metastasis, I'll need to get a CECT, contrast enhanced CT of the thorax and evaluate it further. And if the patient is not a known case of a known malignancy, then this might need restaging and further discussion in the oncology MDT.
Okay, so you give me differentials for metastasis. Anything else that can come up like this?
Other than metastasis, sir.
Correct.
Um, Other than metastasis, multiple lesions like this, infections, multiple in maybe osteomyelitis with the loculated empyema with, so multiple infective foci, maybe in some congenital uh, immunodeficiency syndromes can present like this.
But a lesion in the right scapula, and then you have a pleural based lesion in the left apex, and then you're
Yeah,
seeing a old healed fracture in the right scapula. Can you explain an infection in that background?
no, sir, not exactly. Uh, so um,
Would you just stick with in metastasis if you see a lytic lesion, or you would think of other conditions as well?
lytic lesion.
If I told you this is an elderly patient looking by the X-ray, wouldn't you think of something else as well?
Metastasis, old patient, uh, old patient, lytic lesion, metastasis is the one thing that comes to my mind. What else? Pages will cause diffuse sclerosis and worsening of trabeculae and all. But yeah, the lytic phase of
Okay. So you were talking about the lesion in the.
hyperparathyroidism can, but then the bone density is all normal.
You're talking about the lesion in the left lung apex. What makes
Yeah.
you think that it's a pleural based lesion?
Because it has a wide base towards the chest wall and it shows obtuse angles with the chest wall. So I am thinking it more towards the pleural or the chest wall based lesion. However, the overlying bones appear normal.
Are you sure?
So
Are you sure?
uh, okay, the
Can
first
you can you trace the anterior ribs for me on the left side? On control, can you request for control? I can give you the control.
yes, sir, I will. Yeah, I have requested, but I don't know the windowing. I'm not able to see the anterior ribs at all. It is totally.
But still, to the limited ability that you can see, can you trace the anterior ribs on the left side?
Yes, sir. I'll try to. The first rib is this is the first rib,
Just
anterior first rib.
click the
Yeah,
mouse
the
once.
anterior. Yeah, so this is the first rib I can see.
No,
All
no,
right, the second.
click the mouse
Can
once.
you
Click
see?
the mouse once.
I did. I
Yeah,
did. You're
yeah,
getting an
yes,
option that you're.
I can see you. I can
Yeah.
see you. Yeah, good.
Yeah. So this is the anterior aspect, the first rib. So
Okay.
yeah, the anterior aspect of the second rib is not distinctly visualized. So
Okay.
right, so okay, so this is a okay, so this is polyostotic disease. So this could with expansile lesion like this, one could be metastasis, second could be Paget's. Uh, Others, okay, maybe in not the clavicle, but the rib lesion can be a fibrous dysplasia with ground glass matrix and all. Now, other mm, differentials could be multiple myeloma can present like this.
Do you think fibrous dysplasia can present as lytic lesions in the scapula?
No, sir. No, sir. No, sir. Definitely not. That's what, not the scapula and the rib, only the rib, I mean, sorry, and the clavicle. So my first differential in this case would be metastasis. Second would be multiple myeloma. Third will be Paget's, but lower down in the list, not very likely because other bones look fine and the bones.
So, what would you like to do next?
I would like to do so first I would like to do a CCT of the chest or at least a
Okay. You can
bone
leave the mouse.
scan.
You can leave the mouse once. Yeah.
Yeah.
So I have the same patient's skull X-ray for you. If this can
All
help
right.
you.
Skeletal survey. All right. So the skull X-ray shows multiple variable sized punched out lytic lesions scattered throughout the calvarium. And there is the mandible looks all right. There is no mandibular involvement. And these are punched out lesions. This look like
So
multiple myeloma.
what are your differentials for lytic lesion in the skull?
Lytic lesions, multiple lytic lesions in the skull will be multiple myeloma, hyperparathyroidism, Langerhans histiocytosis in a young patient, not in a mature patient, and metastasis.
Okay. Okay. We shall go to the next case. This is your next case. 1 second. Yes. You can scroll the image.
Okay, sir. So I'll clicked.
Yeah.
I'll just go through the image quickly and all right. So all right, let me just go through it quickly and then get back. All right, I've been provided with an with a no, what sequence is this? Just a minute, sir. Let me just figure out what sequence is this. So with a trophy sequence of liver, which shows which shows differential signal intensity, diffusely heterogeneous signal intensity of the liver. So in a picture like this, I will be thinking, but uh, the liver surface appears fine. I cannot see any focal lesion as such in this sequence. The gallbladder looks okay. The portal vein looks all right. So I'll have to concentrate more on the inferior vena cava and the hepatic veins, because this can be an appearance of Budd Chiari. Let me just slowly go through the images to look for. All right, so I cannot distinctly, okay, there is some hyperintensity within the inferior vena cava and the hepatic veins. This could probably be inferior vena cava with hepatic vein thrombosis, Budd-Chiari syndrome with the differential signal intensity of the hepatic parenchyma. To confirm this, I'll need a post-contrast image to see if there is any opacification of.
Sure, sure. You can leave the mouse. You can leave the mouse.
Yeah.
Yep. Here's the post
Yeah.
contrast image for you.
So this is the post-contrast image. Okay. Right. Right. So let me just have a quick look through this. So this is a post-contrast image with the liver. All right. So yeah. So this is a post-contrast image. I cannot. Okay. Cranially coming from caudal to cranial hepatic vein, the left hepatic
What
vein.
is the striking abnormality that you're seeing in these images?
There are the liver is showing some kind of a differential enhancement. There are some non-enhancing areas in the background of normally
But
enhancing.
that enhancement that you're seeing, does it have a pattern?
Uh, the
Do you think it is very localized? What kind of enhancement are you seeing?
localized diffuse,
Diffused? Yes. More, can you be more specific? What kind of diffuse?
predominantly involving the right lobe.
Okay. No,
Like
no.
it being more
I'm
than
asking you, I'm asking, okay. I can show you another sequence. Can you leave the mouse once?
uh,
I can show you this. Can you scroll this for me and let me know what you think about it?
right. So mm, okay, the veins and all look fine in this. The veins in IVC look fine in this. But the enhancement pattern of liver is not okay.
Okay. But unfortunately, this is not an post contrast. This is
Oh, okay, 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 okay.
use
Is it
what are you seeing in the liver? What is the abnormality that you're seeing in the liver?
diffusely heterogeneous, multiple, so this is a
Yeah.
T2
So
fat sac.
one thing you're sure about, there is no lesion in the liver, correct?
Yeah, there is no lesion in the liver, yes.
Correct. And there is some T2 hyperintense signals, which is not showing any significant, and it's showing kind of a delayed post-contrast enhancement because rest of the parenchyma and the liver is not showing enhancement. But in the post-contrast, you did see that there is a pattern of hyperintensity in the diffuse liver, right? And
Yeah,
in this, you are able to appreciate a T2 hyperintense signals diffuse in the liver, but can you appreciate a pattern to it?
periportal in distribution,
Yes. So if it is periportal in distribution, what could you think of?
hepatitis, periportal cuffing.
What else can cause
Uh,
periportal? If I tell you this patient had pruritus and jaundice, and patient also has associated long-standing history of diarrhea.
area, pruritus, and
Recently,
jaundice.
patient underwent a surgery for malignancy as well, bowel malignancy. Anything that can connect the dots together? Periportal involvement in the liver. Patient has a long history of diarrhea, recent history of bowel surgery for malignancy.
Primary sclerosing cholangitis
Okay.
associated uh,
Right. Right. So
associated with IBD.
correct. So what
Yeah.
else? So unfortunately, what happened is this patient developed a lower limb weakness, and we went ahead and did an MRI spine. This is what. Can you scroll this for me and tell me what do you think?
Yeah, right. There is some lag. I'm sorry. Just a minute. Can I
No
just hold
worries.
it?
Take your time. Take your time. Take your time.
Cranial end. It's a cranial end. Okay. This I've been provided with T2 axial images of the spine. There's a lot of lag. I don't know.
Anything that you find abnormal anywhere.
The spine,
Go ahead. Go ahead. Keep talking.
yeah, so the spine looks, the central canal of the spine looks quite prominent.
Okay.
Uh,
What would you
so
like to do
can
next?
I have the history of the patient again? The patient developed lower limb weakness, is it?
The same patient. Yeah, the same patient developed a lower limb weakness and paresthesia in both the lower limbs.
Okay. Can I have a sagittal of this
Sure.
patient?
Sure. Yeah. Yeah. There you go.
Okay, so so the patient, this is a T2 sagittal of the image of the spine of the cervical spine, which shows long segment T2 hyperintensity of the dorsal column tracts of the dorsal column, which, okay, on the axial it showed an inverted V appearance. So this could be subacute combined degeneration because of the malabsorption or something which is caused by the the IBD. Other than that, the patient has florid degenerative changes of the spine.
Okay. Okay.
So
Yeah. Your time is done. Yeah. Thank you. So, how did you feel? How was the set? I think you had
uh,
seen 4 cases in total. Personally feel you could improve upon your speed. But before that, let me hear what you feel about your own performance.
not very great. I have to
Okay.
talk
What do you
about
think you
it.
could have improved upon?
My differentials.
Precisely, precisely. That's what I feel as well. You
Yeah,
have to, this is my feedback for you for the coming exams. Revise your differentials well.
right,
You are running out of differentials when I ask you
right.
pertaining to different things. So what I would recommend is make a list of differentials that you can commonly encounter in the exam,
Right.
like a lytic lesion, which is very common, and that is an opening case. That is a very common opening case. So you don't want to lose a lot of time. I was checking on your time. You almost took 7 minutes for the first case. I
Okay.
felt you could have speeded up. I can always understand the first case can be a little um, oh, dicey and you might feel anxious and stuff. But then I strikingly felt that your differentials need to be brushed up. Okay.
Right.
But otherwise, you picked up all the findings. The fact that you said it's a plural based lesion, I would have appreciated if you had just focused more on the ribs because once I redirected to you for that and then you picked it up, right? Even though the image quality was quite bad,
Right.
right? So I was expecting you to say multiple myeloma in the first instance along with mets but you were sticking with metastasis, correct?
Right.
So please always keep a set of differentials. Again, when you keep talking, and you just don't say metastasis. I would say that if this was an elderly male in the background of these findings, I would be concerned about prostatic malignancy, in which I would ask for a PSA correlation and also do uh, maybe an
Right.
ultrasound of the prostate or maybe an MR of prostate. The examiner wants you to think 1 or 2 steps ahead rather than just saying metastasis and end it there. Okay. Why don't you put him the conditions? Okay, if I think this could be a renal cell malignancy, I would be expecting a expansile renal metastasis, etc. Right? So that gives
Right.
them a broader perspective of the knowledge that you have in that case.
Right.
Okay.
Right.
The
Okay.
second one, the MR that I showed you, it is quite difficult, I understand. But then this is how primary sclerosing cholangitis can present, and you can be given an MRCP image or simply a T2 weighted sequence or a post contrast sequence where you will not see any lesions, but then you will see a linear hyperintense signals diffusely scattered, which is showing delayed enhancement because of the fibrosis that you just explained, right? Periportal
Right.
fibrosis. And
Right.
such patients, why do you think they can develop SCID? Why do you think they
Uh,
develop vitamin B12 deficiency?
um, Methotrexate,
No.
drug therapy because
No, no. So what happens is in primary sclerosing cholangitis, there is impaired bile acid synthesis, right?
right.
So
Okay.
when the bile acids are required for breaking down the fat micelles, which contains the A, D, E, K vitamins,
Okay.
correct? So once it's not broken down, it cannot be reabsorbed in the distal ileum. So
Okay.
they can be prone for vitamin B12 deficiency. Same patient, if it presents, if they tell you a clinical scenario, if they present with hemolytic anemia with paresthesia, what would you think of? Peripheral smear is showing hemolytic anemia with paresthesia.
Mm,
Vitamin E deficiency, okay? Same. They
right.
both are very close mimicker, but I'm trying
Right.
to tell you to be more of a clinical radiologist so that you can
Right.
correlate all the peripheral smear findings and also
Right.
the imaging findings and think
Okay.
along those lines, okay?
Right.
So thank you so much, Dr. Abhinish. I think you did well, except for the fact that you should revise on your differentials.
That's it. That's it.
Okay. Hope to see you again in the session.
Thank you.
Thank you. Thank you. Okay. Candidate two, are you ready?
Yes, yes, I'm ready.
Are you able to see the screen?
Yes.
Okay. I'll just keep the timer for you. Yes, your timer starts now. You can start.
Provided frontal projection radiograph of chest in a um in a adult patient. I think it's a pediatric patient. However, I'm not able to appreciate the epiphyseal. Yeah. So, striking abnormality I could see is
Can you be a little louder? I think you're a bit inaudible.
okay. Am I audible now?
Yeah, yeah.
Yeah. So, striking abnormality I could see is an opacity in the retrocardiac location. I can see few wires which are externally placed, not able to appreciate any in inner lines and tubes. Okay, so striking abnormality I could see is an opacity which is located in the retrocardiac location. I would correlate if it is a external, I can see an external marking corresponding to that. Other than that, I'm trying to see rest of the lung field. Uh, Other than that, I can also appreciate a opacity, which is located inferior to the diaphragm on the left side, adjacent to the cardiac margin. Coming back
Okay.
to the lung field findings,
Right. So
I
what do
would
you think? What is your primary differential in this case? You were
regarding
talking
the
you were talking about an
yeah
opacity overlying the left side of the heart, is it?
yeah.
Yeah. What do you think about it?
So if the patient presented acutely, and I would think in terms of a mm, pericardial lesion, such
Okay.
as a pericardial cyst. But however, the usual location is the right cardiophrenic ankle. And other possibility I can think is of a aneurysmal dilatation of the left ventricle, but usually there will be a prior history of a myocardial infarction or Yeah, and other possibility could be, um, since it is located inferior to the diaphragmatic margin, and the inferior most portion is it's the caudal portion of the scan. I can think of abdominal lesion as well.
Okay.
In my
What
routine
would you like to
practice,
do next? What would you like
in
to
my
do?
routine practice, I would compare if any previous images if available. I would also check the orthogonal projections if available. Um, I would also correlate with echocardiographic findings. And if these are not available, I would go ahead with an cross-sectional imaging
Okay.
for the
So
characterization.
yeah, this is your cross section. You can ask for control and scroll.
Sure. So provided axial sections of post-contrast axial sections of chest and upper abdomen in the same patient. So the opacity which I could appreciate in the radiograph is seen as a fluid collection surrounding the cardia, the pericardial, uh, pericardiac fluid collection, which is surrounding almost the cardiac margin, predominantly in the anterior and lateral aspect. No obvious calcification noted within this. And the density of the collection, I would check it in the non-contrast sections. So I would think in terms of the underlying possible cause for this. So I would look through the cardiac margins.
Okay. I have another sequence for you. Can you leave the mouse once? Yep. Can you scroll through this and let me know what you think?
So the corresponding opacity, the corresponding to the opacity in the radiograph, the smaller opacity, I can see a hyperdense lesion here with the surrounding artifacts. So if there any instrumentation, prior history of instrumentation, I would think in that lines.
Can I take you back to the radiograph?
Yeah, sure, sure.
Anything in this radiograph that can give you information regarding the history of this patient?
Yeah, let me see. So the smaller opacity, which is quite higher in position. Okay, let me see the.
Please look at all the corners of the radiograph, please.
Yeah, sure, sure. Okay. So this is acutely presented patient because there are spine boards in place, and yeah, trauma is written, so it's possibly a secondary to trauma. So this could be a foreign body, which is uh, and that has led to the uh, pericardial reaction and pericardial effusion.
So where do you think the
So I
foreign
would
body is in?
immediately, yeah, this could be a bullet, it could be a smaller bullet, a gunshot injury. Then in that case, I would check for any history of gunshot injury. Other could be a smaller metallic object, such as any part of an instrument. And yeah, I would immediately inform this finding to the emergency team. This patient require an immediate surgical attention by the cardiovascular surgical team.
Great, great. Yep. This is your second case.
So provided no, still images of nuclear medicine scan. Um, these are the frontal projection. My routine practice, I can see the tracer uptake in the bladder. Um, can I magnify a little bit?
You want to magnify it? Okay, 1 second.
Yeah, the upper portion of the image.
Is it better? Or you want to, which portion of the, where are you suspecting the abnormality?
I'm not able to appreciate any obvious tracer uptake or activity in the lower
How about now? How
bilateral.
about now? How is the image quality now? Have I zoomed it enough?
Okay, let me. Yeah,
No,
I
but
can
then
see
is
that.
there anything abnormal anywhere in the in this image that you think I can zoom it up that part for you?
Yeah. So I can see the bladder activity. So renal activity or yeah, renal shadows also is faintly visualized. I can see some tracer uptake in the uh, uh, left side drips in the mid portion, and
Okay.
also in the I can also appreciate a abnormal tracer activity in the adjacent to the left upper limb.
Okay. Okay.
Uh,
So I can show you that. This is what you are talking about, right? One sec. Yeah, this is what you are talking about.
yeah.
Yeah. What do you see here?
So there is an increased uptake in the bilateral um, sternoclavicular joint. Uh, it's a bull's horn appearance. In that case, it would make it as a um, chronic or recurrent osteomyelitis. I would check if any previous radiographs if available. Also, I can see a increased focal uptake adjacent to the humerus, in possibly in the lateral margin, lateral end of the clavicle, and
Which end?
also the
Which side? Which side?
this side.
Which side? Which side? Oh, on the left side. Okay. Okay.
Yeah.
So you can leave the mouse. You can leave the mouse. Yeah. Yeah. You can leave the mouse. I can show you something. Yeah.
Yeah. Okay. So there is a lesion involving the lateral margin and expansile uh, lytic lesion with the ill-defined zone of narrow, wide zone of transition, and associated soft tissue component, a few multiple permeative lytic areas within it. Which is causing erosion of the lateral margin of the clavicle. Mm, and I'm not able to appreciate. Yeah, I can see some periosteal reaction in the inferior margin of the clavicle. Uh, that could be part of the lesion as well. So, to summarize, a large ill-defined lesion with a permeative and lytic lesion with the permeative areas and wide zone of transition associated soft tissue compound causing erosion of the lateral margin of the left clavicle. I would think in terms of an aggressive bone lesion with the areas of increased tracer uptake. So I would think in terms of an aggressive bone lesion, such as uh, Ewing sarcoma, one possibility. Other possibility would be an osteomyelitis. Other possibility I can think of, mm, yeah, chronic recurrent osteoma, but it's usually more medial in location, and this aggressive imaging features I would consider it as a less differential. So I would compare if any previous images if available. I would refer this patient to a primary bone tumor center. I would further recommend an evaluation with a contrast enhanced MRI for further better characterization of the lesion, including the sternoclavicular joint and also the glenohumeral joint. Thank you.
This is your next case.
Provided a craniocaudal projection of right breast. Striking abnormality I can see is an ill-defined lesion, ill-defined mass located in the outer quadrant, which is hyperdense with uh, ill-defined margins, and few speculations are also noted. So, yeah, yeah, I can see that. I'm not able to appreciate any obvious calcification within the lesion. Uh, However, in my routine practice, I would magnify the images and identify is there any underlying microcalcification. I can also appreciate some thickening, some skin thickening over the central aspect of the breast, and not able to appreciate obvious nipple retraction. Also not able to appreciate a similar lesion, a similar mass or any enlarged lymph node. However, in my routine practice, I will check the uh, medial lateral oblique projection, and also will correlate with ultrasound findings. I would also check the opposite breast as well. Okay. So,
So where do you think the
lesion
lesion
again.
is? Can you tell me the location of the lesion?
Lesion is located in the upper outer quadrant of the
What would you like
breast,
to do next?
and it is in the axillary tail. It's extending up to the axillary tail, actually.
Right. What would you like to do next?
I would correlate with ultrasound finding. I would further refer this patient to one-stop breast clinic for further uh, biopsy, core needle biopsy for further better
This is your
characterization.
next case.
So,
This is a pediatric
provided.
patient who had history of abdominal pain.
Okay. So provided frontal projection radiograph using a barium uh, enema, I feel. Yeah. So striking in a pediatric patient who presents with abdominal pain, striking abnormality I can see is a lucency involving the right lower quadrant, possibly in the right iliac fossa, with mm, uh, with a central lucency and surrounding similar less lucency. So overall, it's possibly a single lesion. Um, and this I can't appreciate any small bowel loop dilatation at this location. No calcification. In my routine practice, I've checked in the control film for better appreciation of the calcification. So, and if the patient is presented acutely, I would think in terms of a in intussusception. Other possibility I can think of a lesion such as a loosened lesion such as a lipoma, which is causing abrupt cutoff of the sigmoid the cecum cecal po- cecal portion of the large bowel loop.
What would you
However,
like
in
to
my
do
routine
next?
practice, I would correlate with ultrasound finding. I would further evaluate this patient with ultrasound. I would also um, check the control film of the patient and enter stack of images,
What would you like to do next after this?
ultrasound and
Okay, okay. And how would you manage if it is intersusception?
yeah, I would manage. I would alert the reference clinician, the emergency team, and pediatrics. I will involve the pediatric surgeon for further reduction of the intussusception.
Uh,
Uh,
yeah.
Actually, the barium enema, if barium enema could also be a therapeutic approach, but usually you can do a saline reduction using rule of three, and also you can use a hygroscopic reduction and you can attempt a
So
hygroscopic
can you
reduction.
explain to me the rule of three?
Yeah, you can do a three attempt in three different pressure settings and
What are the three?
60 mmH, 90 mmH in 120 mmHg for a
Okay.
3 minutes at 3 feet height.
What are the contraindications to do it?
If is there any evidence of underlying free fluid or perforation such as pneumoperitoneum, free air, yeah, and edematous bowel loop also is a contraindication.
Okay, okay. Thank you. So your time is up. You did pretty well. I think we started with this case. Um, if you had seen on the left top, there was a history of trauma
Yeah,
written. So
yeah,
that might have literally brought you down to think about foreign bodies rather than describing the lesions. So
yeah,
yes, this was a case of a bullet injury, which was stuck in the left ventricle. So I think you might could have saved time if you had looked at the corners of the film. And then once we went into the CT, I showed you the bone window where you can see the foreign bodies impacted in the left ventricle, correct? And there's associated pericardial effusion, right? So otherwise, I think you did put the right referrals to the cardiovascular team. And also, this is an emergency, so you have to raise the appropriate referral team for this. Okay, so that was the opening case. This case, I did show you a nuclear scan. Basically, you picked up the pathology in the left aspect of the humerus, but then the lesion was in the left clavicle. You described the lesion well. I felt you could have speeded up a little bit, and all the checklist of a tumor, I think you did mention about it, but again, you could be a little more faster on this. You could have saved a little more time on that. Differentials, I would have expected you to add osteosarcoma as well, rather than sticking just with Ewing's and osteomyelitis. I would have put osteomyelitis way down. Apart from which, you did the referral to the right place, bone tumor specialist center for biopsy and for further staging. So that was okay. This was a very straightforward case, BIRATS 5. I would have expected you to mention that mammography BIRAT scoring was not done. So in real exam, please ensure that in mammography as well, you would say, I would score this as a mammogram BIRATS 5 lesion. And then I would put a referral, I would go ahead with an ultrasound. And
should we say M5 lesion or BIRATS
oh,
lesion?
but for M5 lesion, sorry, M5 lesion for mammogram, and then you go in for ultrasound guided, and then the breast stop clinic, one stop clinic as you described. Okay, and if this turns out to be malignant, breast MDT. So do mention about breast MDT also. Okay, in this case. In this case, you were spot on. This was a case of intersusception, but like you said, you have to put your differentials. Another differential you could give is a meconium, a blocked meconium, but then again, in that case, you would see multiple areas of hyperdensities elsewhere. But then otherwise, the set of differentials that you had given is good. You went for the next correct modality, ultrasound, rather than going for CT. And then even with the management, you were right. But then the pressures that I remember is 80, 100, and 120. So you have to do it 3 times. You do with 80 mm Hg for 3 times, take a break, do it with 100 mm Hg pressure 3 times, take a break, 120, again do it. Then still doesn't work out, then go in for surgery. Okay. So expect this kind of question on intersusception. What are the lead points that can come in intersusception? And then what are the associated differentials that you can think of on barium can also be an expected question in such a case. Okay.
Yep.
So thank you, Dr. Shabib. I think you did quite well. All the best for the exams.
Thank you so much.
Yep. Candidate C, are you ready?
Yes, sir.
Okay. Are you able to see the screen?
Yes, sir.
Yeah, great. Let's go.
Okay, I'm presented with a frontal radiograph of foot. I'm just trying to see the abnormality. I'm just going through the checklist. I did not find any major abnormality in this. There is mild osteopenia of visualized bones. I don't see any. I don't see any evidence of fractures in this. There is no joint space narrowing. No evidence of soft tissue swelling. Okay.
Hello, are you there?
Yes, sir.
Yep.
I just couldn't find any abnormality. I'm just trying to look at the abnormality.
What would you like to do next if you...
I wanted an oblique projection or an orthogonal view for this.
Sure.
Yeah, okay. So I am presented with a frontal radiograph of ankle involving the distal tibia and fibula and also midfoot region. I'm trying to see if there are any. Could I get the history of this patient, sir?
Yeah, this patient has pain in his ankle joint for a very long time and no history of recent trauma.
Okay, no history of trauma. Okay, fine. I could see some areas of, periarticular osteopenia in this patient. I'm thinking it could be a complex regional pain syndrome, I do not see any soft tissue swelling. There are no evidence of fractures.
I think this radiograph would be the ideal radiograph for you to pick the abnormality. And could you trace along the margins of all the bones?
Yeah, okay. So I'm just seeing the distal aspect of tibia. Tibia, I mean, the medial malleolus is normal. Lateral malleolus is also okay. There is no evidence of any abnormality there. Talus, this is a navicular. Here I can see there is some soft tissue density adjacent to this navicular.
What are your differentials?
Mm. Soft tissue density adjacent to a navicular bone. It could be an avulsion fracture of navicular bone.
But are you able to trace the margins of the navicular bone?
Yes, I think the margin is intact here.
Okay. Anything else that you can think of?
Could it be any calcific tendinitis of the muscle or
Great. So which tendon do you think inserts there?
uh, medial compartment? Okay. I'm really not sure.
Okay. What would you like to do next?
Extensor no, it's not okay. I would like to go ahead with MRI for this patient. MRI of the foot.
Okay. Okay. And anything else?
Okay. And I think there is a subtle. I really can't
No,
appreciate any fractures.
that's fine. That's fine. Yeah. Let's go to the next case. Let's wait one sec. I think let's go with this. Yeah. Let's go. You can ask for control.
Okay. Okay. Requested for control, sir.
Yeah. Great. Let's go.
So I am presented with the MR images of the scrotal region. So in the, I'm just trying to scroll the images. It is lagging, sir, on my side.
Yeah. Take your time. Take your time.
I don't know. It is not scroll. Okay. The images are stuck.
Yeah. I think. Yeah. Give me a moment. Give me a moment.
Yeah.
Try this. Are you still finding it struggling for this?
No. I think it's the same image, no, sir, same sequence.
Oh, okay. Sorry. Yeah, one sec. Yeah, try. I think I have reloaded it. Can you? Yeah, I think there are a lot of sequences in this, so probably take your time. I would hold the timer for you. Yeah, take your time.
So yeah, I'm just scrolling through the images. This is MRI of the pelvic region. Okay, I can see there is a very large, slightly lobulated. I'm just trying to find out which sequence is this. Okay, this I don't see any fluids. Okay, fluid here is appearing bright, so it is a T2-weighted sequence.
Okay.
And yeah, there is a large T2 hyperintense, slightly lobulated mass involving the right scrotal sac, and this is compressing. This is compressing the left scrotum. Within this mass, there are some T2 hypointense septations, and surrounding there is a T2 hyperintense fluid signals. If this patient is a young patient, I would think of a seminoma of the testis as my first differential.
Do you think seminoma has a lot of phlovoids within?
What? No.
Would you just quickly narrow down your differentials based on just one sequence?
No, I would want to see post contrast if available.
Okay. Here you go. One sec. I think it's just loading. One moment. I think we can come back to this case later. We'll go to the next case.
Yeah, sure.
Yeah, sure. Okay, so here you can start scrolling.
Okay. I am presented with MRI of the abdomen. Okay, so as I'm scrolling through, I can see that there are multiple T2 hyperintense. There are multiple T2 hyperintense cystic lesions within the liver, and these represents dilated bile ducts. Alternating dilatations and narrowing is seen within this bile ducts, and the extrahepatic common bile duct is also dilated. Yeah. Okay. I do not appreciate pancreas. I'm just trying to see the pancreas. Okay. The pancreatic duct is looking normal. No, sorry.
Are you sure? Are you sure?
The pancreatic duct is also dilated. Sorry. The pancreatic duct is also dilated. So this is giving the double duct sign with intrahepatic biliary radical dilatation and as well as extrahepatic CBD. So I suspect there could be a pancreatic head carcinoma in this or a periampullary carcinoma. I'm just trying to find out if there is any mass in the head of the pancreas. Okay. There is some free fluid in the abdomen and in the perinephric spaces. Okay.
Is there any other sequence that I can help you with?
Yeah. It's a post-contrast sequence.
Okay. Just can you leave the mouse? Yeah.
Yeah.
Here you go. You can scroll.
So this is the second part of the duodenum. Just trying to scroll. Okay. I think this is the lumen of the duodenum. Okay. This is the CBD. Sir, here there is an enhancing lesion, which is this part. I mean, in the enhancing lesion in the head of the pancreas.
Are you sure it's head of the pancreas? Can you trace it back?
Yeah. Okay. So this is the pancreatic duct.
Okay.
Coming. Okay.
I can help you with
I
another
think this
sequence.
is the head of the pancreas. Okay.
Yep. No, but if the lesion is in the head of the pancreas,
Yeah.
You would not expect the dilatation beyond that level as well, is it? I mean, the morphology of the pancreatic head, does it look normal to you or abnormal to you compared to the rest of the pancreas?
Rest of the pancreas is showing the feathery appearance, but head is not showing the normal appearance.
Okay. I can show you another sequence. You can just leave the mouse once. Yeah. Could you scroll this for me?
Yes. So yeah, this is the normal tail and the body of the pancreas. I'm just trying to trace the head.
Okay, keep going.
Okay. Yeah, this
There.
region looks abnormal, yes.
Yeah. So which part is that?
Okay. This is in the duodenum, I guess.
So what are your thoughts?
Uncinate process. Okay. This is the third part of the duodenum, I guess. Okay.
So what are your thoughts?
So I think it could be a periampullary carcinoma, which is causing this double duct sign and dilatation of IHBRD.
Any other differentials?
Or it could be an uncinate process. Tumor. I mean, carcinoma, adenocarcinoma of the uncinate process of the pancreas.
Do you want to have a look in this?
Yes, sir. Or is it annular pancreas which is causing second part of the duodenum? Okay, this is the stomach. I'm just coming down.
Sorry. That's okay. Fine. Let's go to the next case. Let's come back to the next case. Yeah. This is your next case.
Okay. So I'm presented with
You can
flow.
scroll through the images. This is a
Okay.
scroll. There are a few scrollable images. Have a look at it and then you can start commenting. This
So
patient
this is
recently underwent surgery for gallbladder stones.
okay. So okay. I think this is a percutaneous cholangiographic study. This is the scout image. Okay, I can see the contrast is opacifying the intrahepatic biliary radicals, and there is passage of the contrast through the intrahepatic biliary radicals into the common bile duct and into the second part of the duodenum as well. And I can see there is a narrowing in this portion, in the intrahepatic portion. This could likely represent a stricture. I can see the contrast is opacifying the bowel loops well. There is no evidence of intrahepatic biliary radical dilatation as such.
So the gastroenterologist is coming to you and he's concerned. So the cholecystectomy happened a couple of years back, and now you tell him that there is a stricture. He's concerned, is it benign or malignant? Because the management completely changes. So can you help him with that?
So
In other
malignant
words,
strictures
yeah, in
are
other words, how do you differentiate a benign versus malignant stricture?
okay. Malignant strictures are short segment strictures, and
Okay.
yeah,
Are you
I
sure?
think benign.
Are you sure malignant strictures are short segment?
I think I'm telling vice versa. I think the benign strictures are short segment and malignant are long segment strictures. They'll have I mean irregular luminal narrowing compared to the benign strictures, and more intrahepatic biliary radical dilatation. Um, yeah, I can think only of these differences. So
Okay, what would you like to do next?
I would like to correlate this with an MRCP.
Okay. And anything else that you would want to? Anything else that you could think of, like apart from strictures, anything else that could possibly give this kind of
There
morphology?
okay. I mean, there could be a, I mean, filling defect. I could not see any filling defect to suggest a stone, but there could be a mass which is causing a stricture.
If I tell you that
Hilar
this,
mass.
if I tell you this is a pseudo stricture, what comes to your mind?
Okay. Pseudo stricture. This could be, I mean, secondary to post-operative, I mean, like post-cholecystectomy. They have injured maybe they have injured the bile duct and then it has resulted in a stricture.
Okay.
Mm.
Okay, great. I think your time is up. Thank you so much. Okay, let's start with this. So this
Yes.
was a case of cholecystectomy, and post cholecystectomy patient had complaints probably, and that's why the T2 cholangiogram was taken. And you were right. You picked up the finding. There was a tight structure at the level of the CHT, okay, or the proximal CHT. And the difference between benign versus malignant structure is an expected question if you get such kind of cases in the exam, okay? So always remember, a long length involvement is often associated with malignant stricture.
Malignancy.
They
Okay.
say roughly around more than 10 to 12 mm.
Okay.
And you would see very indistinct outer margins with asymmetry. Shouldering is very characteristic. So always remember, shouldering is very common thing, right?
Mm.
And in the when you do a associated post contrast sequence CT, you will see an enhancing component to it, correct? A soft tissue component to it, which can be commonly seen with a malignant structure, right? And also the bile duct thickening will be there. Okay. On the other hand, benign structures are comparatively smooth structures. Okay. And they will have tapered margins. They wouldn't have any irregular margin, like you mentioned in malignant structures. Okay.
Yes.
There is an entity called pseudostrictures which makes you think that there is a stricture which is not. Okay. And it's very important from surgical point of view because it can be caused by compression of the arteries. Okay. So always remember, this is the normal site of coursing of the gastroduodenal arteries and the proper hepatic arteries that can compress on the common bile duct and cause this kind of a mimicking. So always raise three possibilities whenever you're seeing a narrowing in the CBD: malignant structure, benign structure, and pseudo structures.
Pseudo structure. Okay.
Remember all these three entities. Okay.
Okay, sir.
This case, you are right. This is a case of a duodenal malignancy.
Okay.
Yeah. You are picking up the findings spot on, and you can see there is a thickening. There is a soft tissue component here, which is appearing hypointense on T2. And post contrast, initial post contrast did not show any enhancing component, and then I showed you a delayed contrast sequence where you can see there is a thickening around this region, correct? Yeah.
Yes, sir.
Yeah, the pancreas is completely normal. This was a case of a duodenal adenocarcinoma, but from an exam perspective, you can raise the differentials for any duodenal masses. Can you mention any other duodenal mass that you know of that you can raise in this case?
So leiomyoma or gastrointestinal
Yeah,
stromal
just
tumors,
is a good
leiomyomas
possibility. Lymphoma, neuroendocrine tumors, but
lymphoma.
then
Yeah.
always give a conditional. If it was a neuroendocrine, you would expect more of an arterial enhancement, which I do not see in this case. If it was a lymphoma, I would not expect in general it to cause a compression, right? It's more of an encasement. Lymphomas may or may not cause upstream dilatation. So this was a case of adenocarcinoma. Expect questions of wide area of contact. Always when you're seeing a lesion, try to describe, is the lesion having an extra luminal extension, or is it adjacent? Is there any thrombus in the adjacent vessels? It is always a good habit to end the case that way. Okay. I felt in all the cases you were not reaching till the management and referring to the appropriate MDT. So please keep that in back of your mind. Okay.
Okay.
Then I think we'll show it some other day because we just showed it a halfway. This one, I expected you to pick it up earlier because it can come as one of the rapids, not as a case, but then all these in the opacities adjacent to the bone is very common rapids that you can get, right? So, please always look at the margins of the bone. So this was a case of calcific tendinosis of tibialis posterior tendon. Okay, that's where it inserts into the navicular tuberosity. So if you see something like this, think of calcific tendinitis, and always remember they can show you this where they can assess your anatomy and also your radiology at the same time. Okay. Great. So I think we are done with the cases for you. Yeah.
Yes,
Yeah.
sir.
Yeah. Thank you so much for participating. Yeah. Bye. Candidate 4, are you ready?
Hello. Hi, sir. Yeah, I'm ready.
Okay. Do you want to start with a tough case or a easy case?
However, I don't know.
Great. Yeah, let's go.
So I've been provided with a frontal chest radiograph of a skeletally mature patient. Coming to the apex, lung apices, upper zones, mid zones, and lower zones appear normal. Coming to the trachea is central. Aortic knuckle is on the left and is normal. Bilateral hilar region appears normal. Left cardiac border, right cardiac border appear normal. Although I do see few curvilinear calcific densities along the cardiac border, predominantly in its apex or lower aspect of the cardiac region.
Okay, so what do you think about it?
Yeah, so I would like it looks like perichronic pericarditis, chronic calcific pericarditis. The bilateral CP angles are normal. So summarizing my findings, with the curvilinear calcific densities along the pericardial region, I would like to the possibility of chronic calcific pericarditis. I would ask prior imaging if available and any evidence, any prior history of tuberculosis or any infection which could lead to pericarditis.
Okay.
I would inform these findings to the referring physician and also manage the patient accordingly.
If I tell you that this patient is on dialysis, what could be the possible reason?
Okay, so on dialysis, this could be one possibility is abnormal pericardial calcifications because of deposition. The other possibility
What entity?
would,
What entity in CKD can cause this?
uh,
Or what blood parameter that you would see in CKD can cause this in the heart?
it could be hyperuremia, increased uremic levels.
Okay. And if I tell you this is a lady who had recurrent abortions, what would you think of?
Recurrent abortions. So infection with the recurrent abortions, or it could be related to RH positive, RH negative pregnancies, which could lead to recurrent abortions, and
Can that cause pericardial calcification?
not really.
In such patients, what would I find clinically if I examine this patient? This patient had recurrent abortions, and then patient had this pericardial calcification. And what clinical finding will I find in this patient if I examine her?
Uh,
In ideal situation.
patient.
Okay, no problem. Yeah, no problem. Let's go to the next case. You can, one sec, I'll just increase the window for you. Yeah, you can request for control. You can request for control. Yeah, take your time, take your time. You might see it on the top corner, 3 dots.
Yeah, request.
Yeah, great. You can click once and scroll.
Yeah. So I've been provided with T2 fat sat images of the pelvis and upper thigh region, where I do see multiple. Right. So it is till the uh, yeah, till the thigh. So I do see multiple hyperintense serpiginous lesions that are seen along the sciatic nerve pathology, sciatic nerve bilaterally, and also along the bilateral exiting nerve roots through the sacral foraminae. These lesions do not have any infiltration into the surrounding muscles. I also do see few intramuscular and cutaneous hyperintensity as well. Yeah, so summarizing my findings, bilateral hyperintense signal intensities along the nerves, exiting nerve roots in the sacrum and along the sciatic nerve, and also in the intramuscular regions. I would like to think a possibility of uh, uh, multiple neurofibromas or plexiform neurofibroma. I would like to inform these findings to the referring physician and screen for the as a syndromic approach for neurofibromatosis. Maybe see for the cafe-au-lait spots, see for any cutaneous lesions. Then other differentials would be schwannomas, multiple schwannomas. Yeah, I would refer the case out to the neurology and multidisciplinary team meeting has to be done for the further management.
Can you tell me a few MSK manifestations for neurofibromatosis?
Yes, so there can be because of the multiple lesions, which could be a remodeling of the bone because of the long-standing compression. So there will be abnormal lengthening and bowing of the long bones. There will be pseudoarthrosis. There can be, if there is any malignant transformation, there can be infiltration of the bones. Then
Which
there
bone
can
tumor is associated with NF?
MF, osteosarcoma. I'm not sure.
Okay. Can you mention
I would-
one or two GI manifestations of NF?
Right. So there can be multiple polyps within the GI tract. There can be
Okay, no problem. Yeah, let's go to the next case.
So I've been provided with frontal radiograph of right foot, and I do see, coming to the bone density, I don't find diffuse osteopenia. I don't see any diffuse osteopenia. I do see areas of tapering bones. That's significantly seen in the right fifth metatarsal, with surrounding soft tissue swelling with penicillin cup deformity at metacarpophalangeal joint. And also I do see some dislocation with erosions, smooth erosions in the proximal phalanx of right great toe. The rest of the bones appear normal. There is some angular deformities in the right great toe. So the midfoot bones and rest of the bone in the ankle joint looks fairly normal. So in the given image, in the given radiograph, summarizing my findings with the smooth tapering erosions of the right fifth metatarsal with penicillin cup deformity and erosions of right proximal great toe, right distal phalanx of the right great toe. That looks something like a candle licking type of sign here. So my first differential, I would like to think a possibility of Charcot's arthropathy. The other differential would be psoriatic arthritis.
Why would you say Charcot's? What are the 5 common entities that you see with Charcot's?
Right. So there'll be destruction. There'll be increased densities of the predominantly the
Are you seeing
midfoot
them?
bone.
Are you seeing them?
I'm not.
Okay, okay. So, what
And
would you like to do next?
I would like to see prior imaging if available, and it looks.
This patient had associated hip pain, and we did an MR, and radiologist reported it as sacroiliitis. What pattern of sacroiliitis do you think this patient will have?
It would be asymmetrical type of sacroiliitis. So with that
Any
means
other differentials for an asymmetric sacroiliitis?
like reactive arthritis.
So what clinical history would you elicit in that case?
I would like to elicit if the patient has any urethritis, uveitis, uh, uh, and
Okay, cool. Yeah, this is your next case. You can scroll. Yeah.
let me just scroll through once and before I comment on anything.
So the history of this patient is this patient presented with acute lower back pain.
Okay. So the images start with the mid cardiac region.
Yeah, you can start. You can
Yeah,
start
okay.
scrolling any direction. Yeah.
So I've been provided with axial sections of non-contrast CT in a soft tissue window. I don't see any evidence of pleural effusion. Just a minute. I think I had a jump.
Yeah, no problem. Take your time, scroll slowly.
So there is thickening of the anterior renal fascia. There is evidence of left renal fat stranding.
So where do you think the abnormality is? The epicenter of the abnormality?
Let me just scroll back once again. I do see left inguinal omental hernia. Bladder appears normal. Coming to the pancreas and pancreatic tail, quite appear normal. So coming to the adrenals, the right adrenal is normal. The left adrenal, right, I do see the left adrenal, which is almost merging with the facial thickening. But I would like to see in the post-contrast images fairly to comment on the adrenal. But here I do see significant anterior renal facial thickening, which
What are you
appears
thinking about?
hyperdense.
What are you thinking about?
And there are multiple focal round collections which are quite hyperdense and perirenal fat stranding. I'm thinking if the patient has any trauma history, I would like to think a possibility of blunt trauma injury with anterior renal.
Okay. I can give you the post contrast. Can you leave the mouse once?
Yeah, sure.
Yeah, these are the post contrast. You can scroll them.
So I've been provided with arterial face images of post contrast and right. Coming to one of the arteries, right? I do see enhancing foci, which is as enhancing as similar as that of a blood pool within the aorta. So I'm thinking if let me just trace back. So it could be inferior adrenal or inferior adrenal artery on the left side, which is showing pseudo aneurysm.
What would you like to do next? How would you confirm it?
Yeah, I would like to go ahead with the DSA images, DSA, digital subtraction angiography, to see if there is any blushing.
You can scroll.
Yeah. So I've been provided with digital subtraction angiogram images. So there.
So what do you see here?
I do see contrast classification from the aorta and one of the arteries in inferior adrenal artery shows blushing. So that is one point where it could be the possible reason for the continuous bleeding. I would inform this. Let me just see if there are any other areas of bleeders. No.
So that brings me to the question, what is the blood supply for adrenal gland?
So there are three: inferior, middle, and superior, inferior, and middle. Middle comes from the aorta. Inferior usually comes from the renal artery, and superior comes from the phrenic.
Okay, and where do you think this is coming from?
This is coming from the middle adrenal artery, which is a direct supply from the aorta.
Perfect. Yeah, thank you.
Yeah, so
your time
I
is
would.
Yeah, fine, that's fine. So this was spot on. I think you handled this case quite well. This even when it on this plain CT post contrast and the DSA. And the your anatomical knowledge all through the sets were really good. So there's no doubt about it. So I think this case you did well. I would definitely give you a 7.5 on this. Okay.
Okay.
Then I think we started with this, right? I
Mhm.
think I have the same feedback for you on this. Please revise your differentials. This
Okay.
was a case of pericardial calcifications, and always have a 4 to 5 set of differentials when it comes
Okay.
to anything. Okay. So here I would have expected you to talk in the way, if I were in your place, I would have said that. So there is a curvilinear calcification overlying the pericardium,
Okay.
in the background of which I would be thinking of pericardial calcifications. Now, if this was a patient with a previous history of Cox infection or fungal infections, I would have thought along those lines. If the patient is a known case of chronic kidney disease, I would think of uremic pericarditis.
Correct.
If this
Yes.
patient is a young female with recurrent abortions and a malar rash, I would be thinking of vasculitis like systemic lupus erythematosus, right? So this is how you use your knowledge of your differentials to practice so that you can impress the examiner about the knowledge you have, rather than you asking him, does
Okay.
this patient have this history or that history, right?
Okay.
So this is something which I have been trying to advocate ever since we started the sessions, to give bring that approach into your answering. Okay.
Okay.
And this
Okay.
is where you can score marks. These are discussion cases where you can score marks with your knowledge. Okay.
Okay.
So this was case of pericardial, and expect such very straightforward cases, and this is where you have to go out of the
Yeah.
way and score well. This was a case of neurofibromatosis. Okay. Another thing that I always remind everyone is, when any phacomatous syndromes you get, there are two things that you ought to say. One, syndromic screening. Two, family screening. Okay.
Okay.
Screen
Okay.
entire patient for that syndrome.
Okay.
Second, do a family screening. Okay. In
Okay.
this case, any syndromes always have a good idea about all the manifestations in that syndrome. NF1, NF2, von Hippel-Lindau, Stuke-Weber's, and tuberous sclerosis, and Osler-Weber-Rendo syndrome. These 6 are, you have to know it, and
Okay.
all the manifestations associated with it. Okay. So
Okay.
the one which I was expecting you, there are around 10 to 12 MSK manifestations, like rib and rib, and there is a non-ossifying fibrous dysplasia, which is a very common tumor associated with NF. Okay. So they expect you to know all this. So always revise them. GIST is a very common tumor that is seen with NF1. So remember that as well. Okay. Otherwise, this was your description. Like I said, your anatomical knowledge is not at all a problem. You can be assured that that would never be a problem for you in the real exam as well. But it is after that, the discussion that comes with the examiner, that is where you're having problems. Okay. So work on that.
Sure.
This case, the way you described initially, I had a doubt whether you knew it was psoriatic, because you said you were not telling the word pencil and cup. So see, when you see a very classic case of psoriatic, don't drag it too much.
Okay.
Just describe it and say pencil and cup deformity, and you think of an inflammatory arthropathies like psoriatic arthritis. Okay.
Okay.
And you might also put some other differentials. Don't say Charcot's, because that can literally take you off the track when it comes to marking. And you put Charcot's first, not even like second or third. You put directly Charcot's first. You are describing something and you're directly going for Charcot's. I mean, that would make your examiner think this guy has no clue what is he's talking about. Correct. And having said that, always remember everything about psoriatic. They are very hot favorites for UK exams. Okay.
Okay.
Otherwise, you are good with your description. So I'm not very sure licked candy comes for this or leprosy. I think it's for leprosy. But if I'm wrong, do correct me if I'm wrong. This is a excellent cup for psoriatic. Okay.
Right.
Then I think we ended up with this case, correct? I think we are done with all the cases. Yeah. So all the very best, Vivek. I think you are pretty good, solid. Are you writing the September exam?
Yes, I'm writing, sir.
Oh, great, great. All the very best. I think all the 4 candidates did really well. Please practice your differentials set. Okay. And the way I said, this is always try to use, I think I always tell everybody to learn the differentials and practice it yourself. Like, how could you say it better? Like in this case, like how I told you how you could say regarding the pericardial calcifications. Okay. Right. Thank you so much. And I think I'll wind up. Thank you so much, everyone, for attending with us. And I hope everybody found it helpful with all these sessions and cases. And hopefully we'll do it furthermore in the coming days before the September exams come up. Okay. If there is any questions, I'll just wait for another 1 minute. If not, I think we'll wind up.
Yeah, one more doubt. So
Yeah,
in the
please.
first case, the sclerosing cholangitis, when you showed the initial image, can we start with regenerative nodules or dysplastic nodules, like something like that? With
But
the
then
initial-
there was no definitive lesions for you to describe it as regenerative or dysplastic, right? So the pattern that you were seeing were linear hyperintense signals
Hyper-
diffusely, right? And
Correct.
in what the candidate said, there was a periportal involvement, and
Right.
in the delayed contrast, there was contrast enhancement because there was fibrosis involving it,
Correct.
right?
Okay.
So I understand the sclerosing cholangitis may not show up on the exams, but they can show you MRCP sequence of the same, which can be classic findings, right? And
Okay.
so when you the UK these FRCR2B exams are more of dual pathologies. They can show you an IBD and coexisting IBD findings. So in this case, I showed you a primary sclerosing cholangitis with vitamin B12 deficiency, and I gave you history of IBD. So you are supposed to connect the dots and think along those lines. Okay, so they'll always put cases which they can test your anatomy, physiology, radiology, and pathology.
Okay.
Right. Great. Any other questions? Okay, I think if you have questions, feel free to text in the Telegram as well. So once again, thank you guys. I'll end the session right now. Okay. Hope to see you next time. Sunday, probably we'll do another session. Probably Dave can join back on Sunday as well. Yeah. Thank you so much. Bye.
Thank you.
Yeah. Bye.